All right. Well, good morning, everyone. I'm Ricky Telg. I serve as the director for the UF Center for Public Issues Education in Agriculture and Natural Resources. I'm also the co-principal investigator with the Southeastern Coastal Center for Agricultural Health and Safety's Outreach Core. And it's my pleasure to be the host for today's first panel at the State of the Science meeting. We have three presenters and a short video in this first session. We'll provide an overview of health equity as a research practice. The speakers are contributors to the 2021 National Extension Framework for Health, and they will share insights on the background for the updated framework, examples of how it can advance agricultural, fisheries, and forestry health and safety work, and institutional considerations. Some key points from this morning's sessions include the new Extension National Framework and its applications across disciplines, novel approaches and partnerships, and examples some of the new concepts in action. Our panelists for this first presentation are Dr. Michael Gutter, Professor and Associate Dean for Extension here at the University of Florida. He's also the State Program Leader for 4-H Youth Development, Families, and Communities. Dr. LaToya O'Neill, Assistant Professor and Extension Specialist at the University of Florida, and Dr. Roger Rennekamp, Extension Health Director for the Cooperative Extension System. But before they begin, we have a brief video to explain health equity from Dr. Linda Cutler, the Associate Dean for Research at the College of Public Health and Health Professions and the Dean's Professor of Epidemiology at the College of Public Health and Health Professions and the College of Medicine at the University of Florida. Let's play her video now.
I'm Linda Cutler. I'm the Associate Dean for Research in the College of Public Health and Health Professions. And I'm also a Professor of Epidemiology in the College of Public Health and Health Professions and the College of Medicine. And it's a real pleasure for me to open this meeting on the state of the science for the Southeastern Coastal Center for Agricultural Health and Safety. Yesterday, September the 8th, was the 167th anniversary of one of the most important events in my field of epidemiology. It's the removal of the Broad Street pump in London. Removing this pump helped to mitigate the severe cholera outbreak and is now a symbol for public health. What pump handle can we remove today to eliminate diseases that disproportionately affect certain populations? We call these reasons for health inequities social determinants of health, but the CDC has recently labeled them the 7 vital conditions that are needed for wellness. The 7 vital conditions include a thriving natural world. Communities of color are disproportionately exposed to environmental hazards, to poor air quality, and this affects their food and transportation. Another vital condition is meaningful work and wealth. Communities of color and low-income areas are faced with economic setbacks that might take years or generations to overcome. And we need new frameworks to combat systemic racism. There's also reliable transportation. And this vital condition influences where you go to work, your social mobility, and your health. And rural areas are particularly disadvantaged. Another vital condition is lifelong learning. Education ensures that everyone is set up for success, and an increased education is associated with increased income, better health, and more opportunities during your life. Another is belonging and civic muscle. This is about social relationships, social support that's needed to thrive. And people with belonging live happier and healthier lives. Another vital condition is humane housing, which is about a safe and stable place to live. Home ownership is out of reach for many, and a lack of home ownership has been associated with systemic racism, which is linked to thriving and surviving. And finally, vital condition is basic needs for health and safety. So Basic needs like access to care, these are really lacking during the pandemic especially. And a lack of basic needs has led to domestic violence, increased stress, and mental and physical problems. So we need better frameworks. Excuse me. So as you hear the presentations today, think about the pump handle. What can we do to eliminate the inequities and provide for better vital conditions? Thanks, and have a great meeting.
Great. Thank you very much for that, Linda. So right now we will also at the end of the presentation have time for questions, but feel free to type in your questions in the session chat on the right-hand side of your screen throughout the presentation, and I will facilitate the question and answer time at the end of the presentation. So now with Dr. Cutler's video as a foundation on health equity, it's time for our first panel. Doctors Gutter, O'Neill, and Rennekamp, it's all yours.
Very good. Well, thank you so much for having us here, of course. And I'm going to let Roger kick it off to talk a little bit first about some of the roles that we've had and where we're taking this in terms of the origins of the model and what we're thinking about for health equity. So, Roger, take it away, sir.
Well, Mike, thank you very much for the opportunity to be with you all today. And Dr. Telg as well, we really appreciate this opportunity to share some work that we have been doing over the last, I guess, at this particular point in time, 18 months, to develop Cooperative Extension's national framework for health equity and well-being. And we're actually referring to this as a roadmap for systems change in cooperative extension. And as we move through the presentation, I think you'll get a feel for what we mean by systems change in cooperative extension. Again, I'm Roger Rennekamp. I serve as health director for the cooperative extension system. And I'm not a gator like my two colleagues here, but rather I work on behalf of the 100 plus land grant institutions across the country to build the capacity and raise the visibility of the work that their extension services are doing in the area of health. And we really hope that as we move forward as an organization, health becomes a durable and sustainable priority for the work that we do in cooperative extension. So, Mike, if you can go on to the next slide. A little refresher for some of you, but I know a lot of you, and it's good to see some of the different names and faces on here today that I've known at various times in my extension career. But probably a good time for a refresher. And as Dr. Morris said earlier today, you know, the work that you all are doing aligns directly with work with cooperative extension, and we are a great partner in the area of agricultural health and safety. But the cooperative extension system, when you see the word cooperative extension system at the end, we're really referring to that network of all of the extension services of the nation's land grant universities. And one of the themes I think you'll probably see happening in cooperative extension outside of health as well is we're really trying to work more as a system, you know, coordinating the work of more than 100 land grant universities sometimes can be challenging, but we think that when we work as a system, we are better as an organization, eliminating duplication and being able to more appropriately describe our impacts as a collective body. Leadership to those system-wide efforts of cooperative extension are governed by a representative body called the Extension Committee on Organization and Policy, the acronym ECOP. And ECOP established a Health Innovation Task Force in about March of 2020 to update cooperative extension's national framework for, at that time, what we called health and wellness, that was originally developed in 2014. in July, ECOP approved the updated version of the framework to serve as a roadmap for advancing our work in the area of health for the next 5 to 7 years. We also changed the title of that framework from Cooperative Extension's National Framework for Health and Wellness to Cooperative Extension's National Framework for Health, Equity, and Well-Being. Both of those are very significant as we move into the model. We believe that not all people in this nation have the opportunity to experience health, so we know that we need to build an equity lens in what we do. And wellness tends to refer to individual activities, not collective actions that communities can use to either ensure that the vital conditions exist, or in our model, the social determinants of health. So Mike, let's go on and look at the next slide, which is the graphic representation of our model. And Dr. Cutler's introduction was right on target. You know, you'll see a few deviations, I think, in terms of how we refer to a few items in our framework, but her definition of health equity was right on target. And that's really the central focus of all the work we're trying to do in cooperative extension as we move ahead. Well, so as we think about health equity, you know, that involves setting health goals for an entire community or a group of people. But the key here, instead of broadcasting knowledge that we hope improves individual behaviors, we're focusing also on those vital conditions or on the social determinants, with a focus on making sure that absolutely nobody is left behind in efforts to achieve the health goals that we have established for a group or community. But, you know, we know through COVID, we know through the last couple of years that not everyone has a fair and just opportunity to experience optimal health. And that's really where we begin with this model. I talked about the center and the focus of our work being health equity. And those of you that have a big screen can also read that our sub-goals there under health equity are to improve population health, but to achieve equity in health status. So as I said, not everyone has a fair and just opportunity to experience optimal health, and that's because there's some root causes of this structural inequity that exists in society. We wish it didn't, but we know that things like ableism, ageism, xenophobia, racism, as Dr. Cutler talked about, homophobia, classism, sexism, all come into play when decision makers are establishing norms, policies, and practices. You know, these root causes of structural inequity can be intentional sometimes, but sometimes they're unintentional consequences of those particular factors or causes. And as people establish norms, policies, and practice for how they do their work or how we govern, those affect what we are calling the social determinants of health. And, you know, we looked at 8 or 9 different models or organization schemes for the social determinants of health, including the vital conditions. But the model for vital conditions was just coming on board. It's great to hear that CDC has kind of adopted that as their framework. But at this point, what we're using are 9 social determinants of health that were identified by the National Academies of Science, Engineering, and Medicine. And if I start down at housing, we'll go counterclockwise around that ring and talk about just briefly about these determinants, beginning with housing. And one of the things that we know in this country, not everyone has access to affordable, safe, and humane housing. Income and wealth, very similar to one of the vital conditions that Dr. Cutler spoke of, making sure that folks have the resources that they need, the financial resources they need to experience optimal health. Education, and not just necessarily formal education, but non-formal education opportunities like you all provide and cooperative extension provides. Public safety, making sure that they live in communities and in fact are safe. Making sure that also they have access to health systems and services that are needed to either maintain or bring themselves back to health, or even the preventive services that they may need. A healthy physical environment, making sure that, and this also includes climate change and its impacts that are going to be felt over the next, for the next several decades and probably over the next century. Opportunities for employment, social support systems and networks, supportive transportation, and then access to healthy food was not one that was directly included in the National Academy's model, but it was in fact one that we thought we should probably add because of the amount of work that cooperative extension does in that area. Moving in from the social determinants, however, is a ring around what cooperative extension does or will do in the future. If you begin at the top of that ring for cooperative extension, you see the phrase identify and address health inequities. And that means purposefully looking for where those discrepancies or inequities are. Who are the individuals in a given community that are experiencing the greatest health burdens? Who are those individuals that have the barriers to, who are experiencing barriers to achieve optimal health? And as I said, that's a different approach perhaps than broadcasting, knowledge, information for behavioral change to anyone that will listen, to really focusing in and putting special emphasis on those that are experiencing the greatest barriers. And that's truly looking at health issues through an equity lens. Then in cooperative extension, we can go to the right to promote healthy behaviors through communication and education. That has been a mainstay for the work cooperative extension has done in the future, is providing the knowledge and information that folks need to make science or evidence-based decisions about their behaviors. That's still an important part of what we do, as evidenced by the communication of science around COVID-19 and the vaccines. But we also know that education only goes so far in helping people experience optimal health. We also know that we have to focus on those social determinants or on those vital conditions. And that goes to the right of that circle where we talk about creating healthy communities through collective action. So what we hope cooperative extension does in the future, in fact, and we're providing some resources and models for doing that, is working through community coalitions that focus on addressing those health equities through, whether you call it collective impact, coalitions, collective action, but really bringing different agencies, individuals, and most importantly, individuals with lived experience with those barriers to the table to talk about how that community is going to address those barriers and help make sure that all people have the opportunity and have access to the resources that they need to be healthy. So that's a pivot for extension. As some of the folks on today, like Glenn Israel, know, that really involves a community development approach. It really involves community coalitions and that process, moving extension sometimes out of the expert model and engaging the communities in meaningful ways to address those inequities. So, and then we already talked about our central goal of improving population health with a special focus on achieving equity in health status for all people. So, we also added 5 system-wide recommendations that are over on the left side of this model. When we put those recommendations on the left side in that little sidebar, we actually began to talk about this as the big blue fish model, affectionately. But the 5 recommendations that we had for the cooperative extension is, number 1, promote health equity as a core system-wide value, is begin by looking at who are those individuals that are experiencing those barriers to health. Number 2 is integrating data science with resident voice. We know that there have been great advances in data science, including the visualization of data, helping community members beyond academics understand what the issues are through the visualization of data phenomenon in communities. So looking at data science, resident voice, bringing them together in terms of priority setting for communities. We also know that we have to support our extension programs and our professionals through additional professional development opportunities. We also know that this is too big for any one organization to do alone, so we're supporting partnerships at several levels, partnerships and coalition development. We believe that lots of times cooperative extension is isolated in the land-grant university, maybe from some of the other academic units on campus. So cross-campus partnerships will be important. And then also use of community development principles and practices to help our local folks in communities, our field-based staff, build local coalitions to focus on addressing health inequities. So that's our model. And I know you also have a link, or were provided to a link, I think, to our written framework. But I'm going to stop there. And we anticipated some questions coming our way. So Mike and Latoya are going to work through a couple of questions that have already been posed to us. So I'm going to go ahead and turn it to Latoya to take us through a couple of the questions that we knew were already coming. So Latoya, I'm going to you now, and I'm going to mute and take it away, Latoya.
Thank you so much, Roger. Mike, I think you can advance to the first question. So the first question that we received is, how are you defining health equity? And Dr. Cutler did do an excellent job of defining that, but I'll just add that, for many years, the conversation within public health centered around health disparities and providing making interventions, programs, and resources available to everyone, with the thought that this would improve health outcomes. But we did soon discover that in many cases, that approach actually exacerbated disparities, because we made the assumption that if we made it available, then it was accessible, or that everyone had complete agency to adopt certain health behaviors or make certain choices for their lives. But the reality was that just because we made certain resources available didn't mean that they were accessible, or that people didn't experience barriers to accessing them. And so this health equity approach then involves us targeting those communities or groups that are characterized by social, economic, demographic, or geographical status, that are related to barriers, and those who are experiencing poor health outcomes, to develop tailored solutions for helping them achieve optimal health. Next slide. So another question that was posed is, what are some of the challenges in the health landscape that are impacting individual and collective well-being? So the first point here is that more than 750,000 people have died from drug overdoses in the U.S. since 1999. So with the opioid crisis, we've seen many Americans lose their lives. And for people of color, inequitable access to evidence-based prevention, as well as recovery services, also a reliance on punitive approaches to control drug use, and then ongoing economic disinvestment have created even deeper inequities in health related use outcomes. The second point here, during the summer of 2020, 41% of adults in the US reported having an adverse mental or behavioral health condition. So, with this statistic, we found that younger adults, racial ethnic minorities, and essential workers experience disproportionately worse mental health outcomes. They also experienced increased substance abuse and elevated suicidal ideation. And those punitive and criminalizing approaches to mental health and substance use disorders actually contribute to stigmatization and poor outcomes. And those approaches are disproportionately reserved for Black, Indigenous, and people of color. We all saw the impacts of the coronavirus pandemic, which actually reveal those deep-seated inequities in health and healthcare for communities of color, and that have amplified social and economic factors that contribute to these poor health outcomes. Another point here is climate change being a significant threat to human health. In the US, people of color and those with limited income are more vulnerable to things like heat waves, extreme weather events, environmental degradation, and labor market dislocations. Additionally, long-standing racist policies may place more low-income communities near waste disposal sites and other environmental hazards, which disproportionately impact people of color. And then two other quick examples. The rate of food insecurity among Black, Hispanic, and American Indian or Alaska Native households were about 2 times that of white, and that was pre-COVID. So food insecurity has been linked to many health conditions and associated health disparities for things like type 2 diabetes, obesity, and depression, just to name a few. And then finally, families with low income are more likely to be uninsured, and people of color are at higher risk of being uninsured than non Hispanic whites. And so this results in less access to care, including preventive care, more medical debt, thereby increasing the burden of already vulnerable groups. So, those are some of the challenges on the health landscape that impact both individual and collective well being. The next slide. So, what are some of the health inequities that are remediable and part of Extension's framework or Extension's focus with the updated Extension framework? So, we actually have many resources that would help us to identify or surface these inequities in order to approach them. And so this is just one example of that CDC places. It's a collaboration between the Robert Wood Johnson Foundation and the CDC Foundation, and it allows health professionals to better understand the burden and geographic distribution of health-related outcomes. So you can actually look at the census tract levels and visualize disparities in conditions like health, high blood pressure, diabetes, mental health. You can also look at unhealthy behaviors down to the zip code level. You can investigate insurance status, screenings. Um, and so Places provides model-based population level analyses and community estimates to all counties, places, census tracts, and zip codes across the U.S. So no matter where you are, you can utilize this resource down to the zip code level. And so in this map, you can see this is diabetes outcomes. And so this is a visual depiction of geographical disparities, because you can see that um, the darker areas represent higher levels of diabetes. And so you can see that there are disparities across the southern United States there. And so this contributes to our understanding of the factors that influence health outcomes. And so if we can identify the areas where there are disparities present, then we can work down to our county levels in identifying them and then working to actually advance health equity in those areas. And so I think Mike has the next few slides with questions.
Indeed, I do. Thank you so much, Dr. O'Neill. So how does Extension plan to reach audiences regarding health equity issues? And so I want to kind of point this out, that it's going to be, if we go back to the model that Roger mentioned, the first thing is to think about there are numerous individual behaviors that we have worked with historically in cooperative extension that we work proudly with, especially in our rural communities and focusing on our underserved audiences. And these include resource management behaviors, healthy homes, things that we can be doing about healthy environments, as well as, of course, nutrition and food safety in general. But while we've had that proud tradition, the thing that we often don't acknowledge and talk about it as many times too is the context in which an individual lives, works, learns, and plays. So we think about the policies that affect them, the systems in which they have resources, and of course the environment in which they live, eat, play, worship, and all of those things. And so Extension has historically focused on promoting behavior change by helping individuals gain knowledge, attitudes. In other words, we've really talked about how do we help people make different choices. And Some of you know that I study choices for a living, and that's really kind of been a thing that's often challenging, is oftentimes what we're trying to do is to acknowledge that many of the choices that we hope people can make to improve their own health outcomes, the systems in which they're living, playing, working, don't necessarily easily make those possible for them. And that's something that both Dr. Cutler, Dr. Rennekamp, and of course, Dr. O'Neill have kind of been hinting at here too. So while we can have people ready to implement all kinds of positive change behaviors, we have to acknowledge that we have to think about the context for those behaviors. If we'd like people to have a better handle on, if we'd like to try and address some of our cardiometabolic disorders and looking at diet, activity, and exercises, we need to think about in our communities that have food insecurity. We need to think about those communities, do they have safe spaces in which they can play, especially for youth? And so what are some of those opportunities that we have there? This also continues, to think about, Roger also mentioned partnerships. And so some of this is also reaching these audiences by understanding more about where they are. Both Roger and Dr. O'Neill, Latoya both mentioned the use of data. And there's an increasing amount of data, not only that's publicly available, as Dr. O'Neill mentioned, but many of the partners we have in health sciences, they may have access to data. In Florida, we know about things like the One Florida Data Trust and other places where there are opportunities to understand more about health and health challenges across the state. So how does community-based interventions influence these? Well, part of this, first of all, is trying to take us out of the model, taking us out of the expert model only. Our expertise is very valuable in here. Our connections, our relationships, our partnerships, all of these things are very valuable. But coming in there and thinking about how do we work with the community to understand what they see as their needs? What are the barriers to the things that we all would like to see for them, but maybe we don't fully understand those barriers? So rather than coming in saying we can solve your problems, it's going into a community and having them help define those problems in the first place. So we can, in many ways, this is about one of the hallmarks of cooperative extension, local advisory groups, ones that sometimes are ad hoc to address certain new challenges that we have, working together with other county agencies. But as a community engaged partner, cooperative extension can then support some of those collective actions, because maybe it's bringing together people as a convener, a facilitator, a backbone, a connector, or a manager of community health coalitions. A real simple example is trying to understand, in many of our rural communities, we have acknowledged that transportation can be a barrier to various specialty services. Just recently, we had a conversation with those who do engage in medical transport businesses and trying to understand, how can we create a systems approach? How can we make sure that there's people knowing about these resources? How can extension help educate? How can local physicians and others? And so it becomes a learning system of how we're going to bring a lot of these things together. And so that community-based intervention avoids what's often referred to as the helicopter thing. We come in, we have an idea, we might even have a grant, but then we're going to do a thing and then we're going to leave. And this really says that we're going to be part of an engaged community, a learning system where we learn from each other, we bring new things, and then we continue to learn, and that can evolve over time. And that's one of the exciting things about these processes, is it's working with the people and the resources there. It doesn't really involve a lot of outside people coming in and staying in, rather helping to stay involved. And these local coalitions can involve organizations, residents with lived experiences, absolutely should be including young people to get their perspectives, because we certainly know that not only are young people are the future, but as we see with COVID, they're involved and they have thoughts on it too. And so we want to hear them and hear their voices. Why this is so valuable is that community-based interventions have greater success for people and communities embracing them. They feel that it's something being done with them, not to them. And it gives them ownership of an issue as well. And this is very important for things to be sustainable. We talk about wanting to have healthy lifestyles, but those are going to be something that take maintenance on a regular basis. And as a community embraces that, that's very helpful. So all of these things that we do in extension can play a role, from direct education all the way to community facilitation, to thinking about strategic planning with our partners, and so on and so forth. One of the last questions that we asked for, and I think we'll have time for some more, is what are these 5 high-level recommendations? Well, Roger mentioned these briefly. I want to kind of mention this and what this might look like from an organizational standpoint, just to show how it might be operationalized. Number 1 is advancing health equity as a core system value, ensuring that all people have a fair and just opportunity to be as healthy as they can be. Well, this is a little bit of a change, and not necessarily one that people would not like, but as we all know, change is something that we have to manage for it to be successful. And so people like Dr. O'Neill and Roger and others have all come and helped, and we've educated our own extension leadership to help them understand. And recently, we have a strong enough relationship with health sciences here on campus to share the new health equity framework with them. And that's been an exciting part of the conversation too, is to see how they can embrace it. And we appreciate the partnerships we have with people like Dr. Cutler. Utilizing community assessment processes that integrate data science and resident voice to identify and address health inequities. We talked about already how not only can we use the big data that's available to help us understand these, but then going deeper into the data to understand those conversations through qualitative research, local community work that we can be doing, where we're understanding what we can get from the big data sources and blending it with some of the deeper dives. That type of precision approach can really help us be efficient, and in doing so, help us be more effective. We want to think about, too, investing in the success and visibility of Extension's health-related professionals, programs, and initiatives. So making sure that we're celebrating these, that we want these to be understood, that they're valuable to all of our partners. We meet regularly and share this with groups like Florida Farm Bureau. We've been having regular conversations about the types of work we can be doing with Extension amongst our ag leaders and many of our agencies, just so that we can understand that this is an important part of what we're doing in Extension. We have a role to make sure that we're serving in both our agriculture, our forestry, and related communities, fisheries. And as a result, those communities are all made up of people who absolutely have the same challenges as we've seen, whether it's COVID, food security, or the like. Establishing partnerships is key. I appreciate Roger and others mentioning it. I'm glad you got a chance to meet one of my strong partners, Dr. Linda Cutler, with the academics units, universities, government, agencies, corporations, nonprofits, foundations that share a commitment to reducing health inequities. And this can involve having regular conversations, participating in cross-campus disciplines, for example, and ones that are inclusive of relevant state agencies, and in the case of working with Rogers groups, also some of the federal agencies as well. These partnerships have ongoing conversations. They, again, they can start off as ad hoc, but it becomes a commitment to understanding, how do we reach a goal farther off in the future? What are those smaller steps we can take there? And these types of partnerships have a way of growing, because we are bringing together a lot of talent from different disciplines and letting them do what they do best, which is solve some of these very, very challenging or wicked problems, as they call them, or vexing issues that we're facing that really address these social determinants of health. And then lastly, really to use this community development approach to do a good job of making sure our faculty are well versed in this. That involves some of the training we have. So thinking as an organization, how do we be involved and have those voices? How do we make sure those voices are coming out from our communities all the way back up, so that we all have a chance to understand the needs and the changing needs when it comes to these social determinants and the roles that we might play? We found that by being a part of these conversations, we can understand there are things that we can do in these situations that maybe we didn't understand how important they were. Learning more about the systems that are affecting our communities through these relationships, these partnerships, and this approach is something that we think gives us a much better standpoint for how to move forward. So I thank you for your time today. That's the end of the formal presentation. So I will stop sharing my screen. And Ricky, I will turn it back over to you and our good friends here in the audience. So let me stop sharing.
All right. Thank you all very much.
There we are.
Thank you all very much for your time there. It is. If you're not talking, if you can kind of talk into your microphone for a second. Hear myself echoing, I think, on your microphone. It's perfect. So there is time for comments or chat questions. We have roughly 10 minutes left in this session, so please feel free to type in information and questions there. I'll facilitate the questions there. But in the meantime, I'll open it up to any one of you as the panelists, understanding what Mike just presented as those 5 high-level recommendations. We have attendees from not only in the southeastern region but all across the country. If there's one takeaway from the new extension framework for health here, what would that one takeaway that you would say, everybody, this is what we would like for you to leave with today? So anyone wants to chime in with that would be great. Mike's pointing his finger at the screen somewhere, so I think he's going to go ahead and let Latoya or Roger take that first one.
I think the one of the big pieces I think there, I mean, one of the take-home messages, is again, that first goal of really making health equity as a system-wide value. And I think historically, I've spent parts of 5 decades in cooperative extension, and over that period of time, I think our primary model of working has really been to present information to anybody that would listen, and I think that main take home from there is really a transition to find out, in any community, there's people that are already thriving, there's people that are struggling, and there's people that are suffering, and I think the key is looking first for those that are really have barriers to, looking first for individuals that are really having barriers to achieving health equity. So I think health equity is that piece, and that's the big shift there. Instead of broadcast, moving towards precision practices, just like almost like with precision agriculture, and that kind of stuff. You don't fertilize the field that doesn't need it. You put it where it's needed, and that's I think is a very good analogy for really thinking about how we would approach the populations we want to reach. I see there's a question from Glenn.
Right. So Glenn Israel asked the question, when thinking about systems change, what would you say are the major changes occurring or needed compared to what has been done in the past? Mike?
This is just a little bit of what I'm seeing here. So, and I'm sure Roger and Latoya may have other perspectives. Some of the major changes I'm seeing is, the first is one that Roger and a few of us highlighted, is the need to really take a systems approach at how extension sees its role in this, to understand what those solutions might be in these circumstances. And I'll give you one quick example if I could, and then I'll turn it over to my friends. And that's one of the things that we've seen in Florida over the last few years is really a diminishing amount of rural health access. Less clinics, less specialty care. There's diminishing amounts of even pediatricians in many of our rural communities. And so that led to a systems-wide change, right? And a real investment in saying, it's important that we make access be an issue. That's not just direct education, but it did lead to a collaborative grant with the Diabetes Institute and the Cancer Center to place telemedicine kiosks in 13 county offices. They can connect to a lot of value-added programming, but it makes a big difference as we start thinking about, this may actually make a major impact in these families. Just the fact that they now have a much more convenient way to address specialty care, which in the case of some of these patients is as much as a 2-hour drive to get to an oncologist or an endocrinologist. That's a little bit of it there too, Ricky, is just Dr. Israel, is just, it's changed how we think about what we can do. It's just opened the playbook, is I guess the way I would see it, sir. And I think that that's a major shift in thinking. It was for me as an administrator in extension. So Dr. O'Neill, Dr. Rennekamp.
Yeah, so I'll just add that I think about how we approached, and Mike alluded to this earlier, this expert model. And so, when we're working with communities, I think one of the recommendations is, working with coalitions and working through community action. So taking those community engaged approach and really developing coalitions where everyone can work together towards the same mission or goal instead of working in silos within communities. And, this organization is working on this issue. And, we found that a lot, especially with our COVID-19 work, a lot of us are, taking the same approach, and our goal is the same. And so, it's very critical to work with our coalitions and through our partnerships in order to advance health equity. And I think that's a bit of a different approach that will need to be adopted.
Thanks, Latoya. I mean, that was kind of the direction I was going to go on that question too. I think that's I think that's exactly right. The only thing I would add to that too is that we need to figure out how to recognize and reward our extension professionals at the county level for working in new ways, because I think historically, we have looked at metrics like the number of people reached, how many people came to your trainings and your workshops and things like that. And was your teaching score a 4.51 or a 4.52, and how good of a teacher you are. So we have excellent teachers, and that really supports that direct education for behavioral change. But, I don't know that we have figured out in our organization how to really recognize excellent performance as a community convener, collaborator, manager of a coalition working as a backbone organization. So I think we really have to retool in terms of how we recognize that work, because in a lot of cases, that work that we would do in community coalitions to change the entire landscape of the community affects so many more people than you would have even in a workshop of 100 people. So figuring out how to reward that. And then the other piece, I think, is we also have to increase our professional development for our county-based staff, in terms of how to convene, manage, facilitate, be a backbone organization, back out of that expert model into a community engaged model, to do that work. So two things is reward systems. The other one is professional development is the way I think about it, Glenn.
Great. Thank you for that. And that's probably going to be our time for this morning. We're almost at the end of our session. I want to thank our presenters this morning. Thank you all so much for your information and your guidance on this new framework for extension. I do want to make a couple of quick announcements. One is, and this is in the chat, that if you're interested in what the framework looks like, if you scroll down on this page that you're in Hopin, there's a link to the framework and to the executive summary of the framework as well. So please feel free to do that as well. Also, a couple of other things. One is our next session will begin at 11:15. You'll need to click on the sessions button on the left-hand side of your screen. But in between time, I know one of the things that we miss in not having an in-person meeting is those in-between times outside of a session, talking with our coffee and water cooler talk or whatever. So there is the opportunity for you to use the networking button on the left-hand side of your screen there. If you click on that, you'll be taken to a networking site where you can meet one-on-one or in small groups with someone here. And again, one of the reasons why we do these State of the Science meetings is not only hearing about what's being done, but also to build connections with not only the presenters, but also with people who are participating as attendees. So please feel free to take advantage of that networking that will be available all day and actually until after the meeting this afternoon for I think at 2:15 or so Eastern time. But when we start again in about 5 minutes, you'll need to click on the next session. And again, thank you all so much for presenting today. Thank you.